All right, well, let's get started. Thank you very much. It's 2:15. It's time for the surgery committee. My name is Flavio Roca. I'm the surgery committee vice chair. The committee is chaired by Dr. Syed Ahmad from the University of Cincinnati, who sends his regards, but he was not able to make it last minute due to a family thing. But he is here with us in spirit. Our first speaker, actually, it's my pleasure to introduce Dr. Lisa Kacznick, who is our executive officer from SWOG, and she will kick us off.
Do we have slides? Hey again. Oh, I have slides.
Do you have slides? Did you?
I sent them to you twice. Okay, I don't need them.
We got them, but.
It's perfectly fine. If folks were at the plenary, they saw part of it. So, do we have any new folks in the room, or are we online too, on Zoom? Is there anyone new? Well, hello. Maybe we'll go around the room, but I will then present some new things for new people. So, as an executive officer, I help to shepherd science and also other things. And I am the executive officer. I'm a radiation oncologist for the new people to the non-disease site groups, the support groups, which is for us here surgery, but I'm also radiation oncology and imaging. There's a lot you can do in a support group. The support group's like the most, we
have your slides up.
Hey, it's okay, good. The support group is so important because, we set surgical standards on trials. Many of the surgeons are really important co-investigators, but there are opportunities to do our own trial, and we might be embarking on one we just presented at GI very soon, or for secondary analyses. And I would have to say, Dr. Sy and Flavio have had such great monthly meetings that many of the folks in the room can attest to, where we really work together to develop secondary endpoint questions that may inform standards of care changes or trial ideas. Okay, good, rushing me along. So that's okay, you're doing well on that. There's also, for new members, there's travel grants. So, feel free to reach out, or, really you could just go on the Hope Foundation website and you'll find many of these things. You just saw this at plenary, but I just put 4 here that you might be interested in. The first one is the writing workshop. It's okay, I can talk without the slides. The RFA for that's due May 1st, but pretty much if you apply, you will be invited to participate because it's virtual. So there are also 2 different seed grants. The one on top's you just heard about. Did folks go to the plenary? So you just heard about NCORE, so I don't need to describe what it is. But they're $50K awards. If you have a question that pertains to patient-reported outcomes, survivorship, kind of cancer care delivery in the community, so it could be a surgical feasibility type question for a community practice. Those grants are due June 1st. They're very short. We can shepherd you if you have an idea and help you write it. The Hope Foundation CETA grant is due July, also $50K awards. It could be translational. It could probably even support a secondary analysis. It could pretty much be anything if, again, it leads to potentially something practice changing or informs a trial idea. And then some of the larger awards, the Impact Award is the letter of intent's due also in July. Those are larger awards. They're $250K because they're really trying to kind of buy down your time at your home institution so that you can really do the work. So those are a little bit more competitive, but honestly, I am often involved in the reviews. Sometimes they ask me to review a trial that I'm, a grant that I'm on. The N is not that large. So, like the seed grants, there might be 8 in a given year. So you have a really good chance. So, we can help you if you have an idea also on our monthly nighttime, Monday night meetings to walk you through it too, or a separate call. Next slide. So I have even more recent news. So I don't know if folks, I noted while I was flying here on Twitter that our NCI director is stepping down, and he's been really good to the adult cooperative groups. However, the current associate director, Dr. Lowry, is stepping in as the interim acting, and he has a great relationship with SWOG and the other adult groups, so nothing to worry about. You just heard, actually my other news you really just heard about at the plenary, you heard about the group chair elections. If you have anyone you would like to nominate, you can tell me and I can pass it through, or you can let our head of statistics, Mike LeBlanc, know, or just let Dr. Flavio know. And then you saw also from Dr. Blanky, we have a lot of DEI, great stuff going on right now. However, I don't think we have a representative for our support group, so I will raise that up when we have our next leadership meeting next week. Folks have any questions for me? All right, well, enjoy the surgery committee.
Thank you, Dr. Kacznick. So our guest speaker today, it's my pleasure to introduce, is Dr. Alex, I'm going to say it correctly, Guimarães, because he is a fellow Brazilian, native Brazilian like myself. So not that that was anything to do with this selection. But in any case, Alex is trained, went to college in Michigan, went to medical school in the Harvard MIT program, and then did his residency at the Massachusetts General Hospital, where he then stayed on staff for the first 10 years of his career before we were lucky to recruit him to OHSU, where he currently serves as the professor of radiology and the vice chair of research. And Alex has been a very an amazing partner in our pancreas cancer program, really kind of spearheading some of the imaging research, partnering with other cooperative group trials. He's obviously been a member of the Akron group before it was even ECOG Akron, and we're happy to have him at SWOG here today. Alex.
Thank you. I'm going to just make sure that my mic is off here, so I don't get any interference. It is. It seems like it. And let me just go back to this. Figured out. Well, thank you. That was a really nice introduction. I think we come for these talks just to get introduced so we get a little bit of an ego boost once in a while. So for this group, I tried to kind of tailor this talk a little bit on showing, I'm a translational imaging scientist, but trying to kind of focus and teach a little bit about radiomics and where we are in terms of therapeutic response, but kind of give you my perspective as a radiologist from pancreatic cancer. I think the multidisciplinary tumor boards are really where we intersect, other than in the reading room. These are my disclosures. So this is really, I think, how surgeons really see radiologists in terms of pancreatic cancer. Really, what is going on with this patient? Can you silo this patient, and can you help me stage this patient? And the challenge really is pancreatic cancer, unlike many of the other cancers that we deal with, is really infiltrative, amorphous, difficult to measure, has very low reproducibility in terms of measurement, and so numbers really don't fit the scheme of pancreatic cancer a lot of the times. And so therefore, there are many unmet needs in this space. I think the holy grail really continues to be, is this patient responding to this neoadjuvant therapy? And I can never answer that question, because I'd say half the time it's a flip of the coin. But I think in the end of the day, this is where I think we serve the best need and the unmet need. But I think this is the area where we need the most work. RESIST is really helpful because it's statistically fairly robust in some ways. But at the other end of the tail, for diseases like pancreatic cancer in the neoadjuvant setting, it needs a lot of work, because if your reproducibility is so low because you tie a bunch of radiologists into a room and you make them measure the same lesion and you have a variance that's above 25%, but your therapy is going to be only 15% efficacious, then I think you're not going to really give a good therapeutic response and assessment. And that's one of the challenges. So I think in terms of pancreatic cancer, what I see as the radiologic unmet needs are early detection and where you need really sensitive imaging tools, in addition to obviously circulating biomarkers of one sort or another, accurate nodal assessment, and therapeutic response. And I think if we make major strides in those areas, I think we will improve in terms of our ability to assess therapeutic response and assess whether or not therapies are working. So those are unmet needs. When Dr. Roca invited me, he said to focus a lot on radiomics. I thought I'd maybe spend a little time just talking about what radiomics, does anyone in the room really feel like they understand radiomics? Other than you. Don't answer that question, Mike. So radiomics, I think, is a really challenging area. It's exciting because it's really at the intersection of where imaging is with deep learning and AI. And that's really what's exciting about it. And we finally have the computing power to answer some of these questions. But there's still a lot of work to do in this space. What it is in terms of workflow is, let's say this is a patient with esophageal cancer. It's a segmentation that allows you segment out the tumor, and then when you segment out the tumor, you get all of this information about pixel values. But there's a caveat. What happens if you segment out that tumor with no contrast? What segment out that tumor with arterial contrast? What happens if you segment out that tumor with portal venous contrast? And it's a CT. What happens if it's an MRI and you're looking at a T1 in and out of phase, diffusion-weighted image? How do you aggregate all of that information together? And you have millions and millions of numbers. And so what happens is that you utilize these numbers, which are what some people refer to as textures, to then ask questions and model response. And then so most of the radiomics issues are basically allowing you to utilize those numbers in various orders, right? And the traditional is size. Size is a radiomic feature. Shape, volume, those are all radiomic features. But as you climb and have more sophisticated computing power and numbers, you can actually start looking at the interaction of one pixel to another and the correlation of one pixel to another. The standard deviation, right? If it was all like white, that would say something. If it was white, gray, black, that says something. And the numbers start telling a statistical story, right? And so you have what are called first order features, and then you have really higher order features, really complicated statistical algorithms that talk about what the relationship of one pixel is to its neighbors, and then those neighbors to their neighbors. Essentially a virtual map of tumoral heterogeneity radiologically. And then utilizing that, then you can start doing very sophisticated kind of statistical analysis. So let's say this patient here is undergoing, this is a metastatic patient with colorectal disease, is undergoing some level of therapy. We can all say, in this room, this is more homogeneous, it's gotten smaller, this patient's responding, right? But you can actually do the radiomics problem and start looking at what does the histogram of those pixels look like? Is there a leftward shift? Is there a rightward shift? What does the combination of those look like? Then I can convolve that information with a lot of the circulating tumor assessments, circulating tumor DNA, genomics, is this a P53 or not? The challenge is, how do you make those conjectures if a radiomic assessment doesn't necessarily have a histologic correlate? And that's one of my, at least, chief complaints about radiomics where it is today. There's been a lot of work in this space. This was one of the first, at least, pancreatic cancer articles that came out out of Indiana. And Kumar Sandaragesan basically looked at and just basically did an ROC analysis. He said, well, if I do a region of interest analysis of the pancreatic cancer itself, I take the median, the sort of the 50% level, I use that as a cutoff value, and then I make ROC curves around this mean positive pixel value. Can I actually look at overall survival as a result of that? And that actually separates the Kaplan-Meier curves fairly well in the later portions, but in the earlier portions, not as much. I think one of the people that's doing a lot of really elegant work is Eugene Coy's group at MD Anderson. because he's starting to look at things that he's trying to make mathematical assessments of what we as radiologists see on a day-to-day basis. And so one of his first papers was basically dividing response measurements in patients with pancreatic cancer undergoing neoadjuvant therapy into two domains. A type 1 response is, well, I can see the lesion a little bit better. It becomes more well demarcated. That's a type 1 response. It remains or becomes more defined. And a type 2 response was, well, it seems to become less defined or more homogeneous, and the contrast permeates it a little bit more. He then sort of made those two constraints and then sort of did a randomized study that looked at chemoradiation in metastatic patients with pancreatic cancer, and then in patients that were undergoing neoadjuvant gemcitabine and radiation therapy. And the objective was basically, does this work? Does this help me in terms of my response assessments? And he basically saw really nice responses, that standard chemo-RT saw good separation of the two from type 1 to type 2 in terms of the Kaplan-Meier curves. In metastatic disease, not as well. And he applied this in a blinded way to a registry trial where he didn't actually have access to the sort of the hypothesis being tested up front. And again, later separation, but not as well early. His group has gone on to then actually look and try to mathematically assess this boundary issue a little bit better. And sort of now he's dividing these region of interest measurements and trying to come up with a tumor to non-tumor border, I think, contrast mechanism. And then classifying tumors as what are called high delta, meaning that you have a sharp differential between enhancing normal tissue, what you feel is normal tissue, as the radiologist does, versus not. And then low delta, this idea, this one that would be more like type 2, where you sort of have permeation, it's more homogeneous. And then, but he's starting to then do the more classic radiomics questions as, what do those tumors actually correlate to in terms of genomics? Are those all KRAS positive? Or what do those tumors start actually responding more to immune checkpoint inhibitors? Are those more sensitive to Folfox or FOLFIRINOX or Gemabraxane? Classic questions like that. And so he, in this particular paper, then looked at numbers of patients that had this quote-unquote high delta versus low delta type tumor, and then asked the question, how do they, if you have upfront surgery without neoadjuvant therapy, do low delta patients or high delta patients respond better, right? And again, good separation of the Kaplan-Meier curves. And this is sort of the way radiomics is kind of moving with good hypothesis testing from my perspective. But I'll give it the caveat, usually single institution studies. This is actually what he's been working at now, is basically then starting to do second order differential equations, sort of looking at the slope of this. Like if you actually look at this tumor on the right, this is a this is a high delta tumor. This is a low delta tumor. And then you can start really doing some complex math based on that shape and those trajectories. So this is a kind of where we are today. This is a review article on radiomics that I think that was published last year. And I'm not going to, it's a busy slide. My only point here is the majority of the studies that are coming out from most single institution studies, I would say have a low number of patients, right? Like 25, 20, 17. That's one thing I would criticize. Also, if you have the number of features that you're seeing that correlate with statistical significance almost as much as the number of patients that you're studying, I give a little bit of sort of pause at what I can reflect from that, because I don't know what does the sum mean or the entropy value actually correlate. How does that actually, what's the meaning of that with regards to patient outcomes, other than a separation of the Kaplan-Meier curve in one institutional study? And similarly, the challenge also is we don't have a good choice of which software we're using to actually make these delineations. Am I doing my time? Good. And so there's lots of issues that I think we need to solve with this radiomics problem. The publications continue to increase exponentially, to be quite frank. And so where radiomics is now in terms of when you're reviewing a radiomics paper, you want to assess a variety of different features. One is reproducibility and repeatability. Are they doing things like that to better understand the variance of their topics? And so now the literature is really asking you to assess a lot of different features for you to believe the summary and the results that are being derived from those papers. And so you have what are called radiomics quality scores that basically rate a variety of different indices to give you a judgment call on whether or not this paper and this technique is actually, essentially of high or medium value. Where I believe the field should go is basically start doing a little bit more of the rigor associated with, making imaging a very robust imaging biomarker. Do reproducibility studies at your institution if you're going to then understand what the variance of the measure that you're doing. Correlate multiple lesions within the same organ, right? Because what we don't have a good idea of is, let's say this patient here who has breast cancer and metastatic disease, do the measures that are seen from a radiomics assessment in this lesion here in the right lobe of the liver correlate to the ones in the left lobe of the liver? And is there meaning in the difference between those two? And is that a reflection of tumoral heterogeneity, or is that a reflection of just the math and radiomics? And then what we need a little bit more of in the radiomics world is a more tangible assessment of what a radiomics feature is to a histologic or electron microscopy or some kind of correlate, so that better hypothesis-driven testing and or clinical trials could be gauged on a radiomics signature that may essentially correlate to some specific hypothesis being associated with a treatment. And so one of the things that we were playing around with at OHSU is we have these precision oncology trials that Joe Gray and Gordon Mills were running, and we have a lot of this data in place. We're doing multiple biopsies, serial biopsies occasionally on patients with a variety of different malignancy subtypes, but we do have all of the correlative imaging to play in that role. And so what we can do is essentially start asking questions about what does entropy or gray level coherence or these other things, what do they mean with respect to changes in electron microscopy, histology, and multiplex immunohistochemistry. What's also lacking in the radiomics world is a phantom, some means by which to standardize machine X in Seattle to machine Y in Portland. Those are coming into the play. I do know that that NIST is actually making a phantom now towards that end. But we also don't have what are called digital reference objects, meaning a means by which to make software tool X and software tool Y gauge themselves and calibrate themselves with something that's known, a gold standard, a gold truth. And so we need to, and so I would charge that a small subset of patients should be thought of to actually, or utilized to do multi-vendor platform assessments to see if, my radiomic signature on my pancreatic cancer on a GE device in Portland is the same as it would be on a Siemens device in Seattle. And so the standardization is something that's lacking, but that's the direction that the field is going. And I think, there's good leadership in ECOG and SWOG towards that end. So from my perspective, in summary for the radiomics section of this sort of talk, the problem that we have with it is a problem that I think is seen a lot in some radiology literature, is very interesting, exciting results, but not a lot of rigor in terms of understanding the meaning of those results. So what we need is more standardization, validation, and making this less of an overfitting problem and more of a hypothesis-driven solution. And so many of the improvements continue. This radiomics quality score is a great idea. This transparent reporting, multivariable prediction, this tripod issue is another means by which to judge the quality of these radiomics papers. And that kind of work in addition to some histopathologic correlate to some of these measures, I think is moving in the right direction. So that being said, radiomics is not only a CT issue. And so my focus on my work is more on the MRI world. I like MRI because it's kind of like the ultimate stereo. You have like buttons everywhere and you can sort of tweak your contrast and you can look at anatomy, flow, function, oxygenation, and a lot of different other things. Pancreatic cancer and MRI don't necessarily always speak the same language because at the end of the day, most pancreatic cancer patients are followed by CT. That makes the data set rich for radiomics and CAT scans, but I think that there's room for MRI in this space. So for instance, there's been some interesting work looking at T2 relaxation as a biomarker of response and a biomarker of disease. T2 relaxation T2 is one of the relaxation mechanisms of MRI. It's very focused on liquids and inflammation. And the challenge is, in the upper abdomen is that you actually have to take multiple series to quantify this result. But you can look at changes and you can look at absolutes and assess things. So this is an animal study that was done from Bob Gillies and the Moffitt group. And here they looked at at basically radiation therapy and the effect on pancreatic cancer in mice xenografts. And the reason I show it is that you can actually do the same kind of radiomics assessment, but look at changes of influx of inflammation, so to speak, or increases in necrosis. And so what they did here is they saw that T2 was essentially a biomarker of response, and that you saw increases in heterogeneity of the T2 map, or this T2 relaxation measure. They actually then looked at the histologic correlate as well and saw that regions that had changes in T2 were more focused on necrosis, and viable tissue had less of that change. And so a means by which to assess the golden question that we have a lot of the times is there viable tissue in this pancreatic cancer that I've been treating with Gem-Abraxane and radiation therapy? The challenge of doing this and translating into humans is that the upper body moves. And so one of the challenges of quantifying T2 in the upper abdomen and many other relaxation parameters is that you have to do multiple breath holds, and you aren't guaranteed that your pixel doesn't move through space and time. And so a lot of my work focuses on magnetic resonance fingerprinting, which has kind of thrown MRI upside down. It's a randomized approach to the acquisition where you fit all of the relaxation parameters that are governed by the equations that sort of govern all of MRI. But then the benefit is that you can then quantify T2, T1, and T1 row or other relaxation mechanisms all within the same voxel with confidence because the acquisition scheme was all spatially governed in that area. And so that, at least for me, is more mathematically and quantitatively robust and allows you to build models around those ideas. It actually correlates quite well in phantoms and in humans with regards to all of these relaxation mechanisms. So if I made a varying T1 phantom or a varying T2 phantom, I do these experiments, they correlate quite well. T1 row is something that's actually upregulated and changes a lot with collagen and fibrosis. And so this is some data that comes out of our institution where we actually were doing this with patients with chronic pancreatitis. First question was, does fingerprinting and does free breathing and breath hold imaging actually with fingerprinting do the same kind of results? And it actually, from a subjective perspective, they actually look quite similar. And so that's actually helpful because the patients tolerate free breathing much better and many of our patients with pancreatic cancer are older. And so this is one of the questions we wanted to answer. We did actually ask the question whether or not there were changes in these relaxation values that correlated to chronic pancreatitis, and saw that there were changes. All of them correlated quite well. T1 row, T2, and T1 all had different changes that we can quantify. And the reason why that applies to pancreatic cancer is one of the things that we're writing a grant actually as a means by which to use fingerprinting as an early detection biomarker, because in the Panin spectrum, inflammation and collagen are part of the Panin spectrum, and we think that this may be a non-invasive, non-contrast way of actually looking at that question. There we go. Diffusion-weighted imaging is another contrast mechanism that has actually played a role in pancreatic cancer, another sort of knob on the stereo. Here you're looking at water density, and so the idea here is malignancy and essentially high cellular organs like cancer restrict the ability of free water to move, and so you're very sensitive to that space, and so and you can actually quantify an apparent diffusion coefficient, so you actually have a number, an assay essentially of the apparent diffusion coefficient. And so rather than an assessment of a variety of different biomarkers like radiomics, you actually are holding on to one hypothesis, is this, I lost the feed. Oh, okay. Usually this is when just people are leaving the room because they're bored with what I'm talking about. This is sort of a virtual leaving the room.
Can our virtual attendees see the slides? Yeah.
Oh, there we go. We're back. Okay. Perfect. Okay. So you can quantify the apparent diffusion coefficient. This has actually been looked at in pancreatic cancer. This is kind of post-neoadjuvant therapy and, on the left, pre on the right. RESIST didn't show no essential changes, but you did see changes in T2 that you could quantify and changes in the apparent diffusion coefficient. In summarizing a variety of articles, most of them show the same kinds of findings, that the apparent diffusion coefficient changes upwards, meaning that you have better diffusion and better water mobility in patients who respond to neoadjuvant therapy. That basically is not incongruous, but more sensitive than something like RESIST, where the tumor hasn't changed size. Probably for a variety of reasons. One, you're having an influx of inflammation. Two, you still have desmoplasia. So there are a variety of reasons why the tumors aren't shrinking, like, the easy one, right, which is colorectal. They all shrink. It's great. We love that. It's easy. It makes my life easy. And so that story is actually one that's exciting, but probably combining that with a variety of different biomarkers may lend itself to a better story. And then lastly, my work is focused a little bit on nanoparticles and microvascularity. That story basically, I'm sensitive to the time here. That story is basically focused on tumor microvascular normalization. And so I inject nanoparticles, I quantify relaxation parameters, and then I look at the effect, both with histograms and mean values and things like that, of collagen disruption agents. And so in this particular context, we did the story of assessing losartan's effect on orthotopic pancreatic cancer, and saw that vascular volume fraction, which is a biomarker of tumor microvasculature, was upregulated after losartan. And similarly, you saw changes in DAPI, which is a histologic correlate, vessel size indices as well. You can actually make a map of vessel sizes and show those changes and see a rightward shift after losartan, all implying microvascular normalization. We actually then asked the question and labeled 5-fluorouracil and asked the question if losartan actually improved drug delivery, and then quantified that by basically doing regions of interest in the tumor and in the aorta, and saw that you had about a 50% increase in drug delivery. And so we've done that in humans, just to show one example. This is a patient who, a 67-year-old who underwent a Whipple, had 7 cycles of FOLFIRINOX, and then we did the same kind of microvessel assessment and saw a similar rightward shift. More vessels, more blood volume after losartan, after FOLFIRINOX. This patient didn't receive losartan. But where I think the story is actually heading to be honest, is in the molecular imaging realm. There's a lot of excitement about this paper that came out of Mayo with, that really was interesting to me because the story when I was a resident of FDG and pancreatic cancer was that we didn't use it because it was not, quote unquote, as unreliable. Once in a while it worked, once in a while it didn't, and so therefore it wasn't really that reliable. The Mayo story was actually a really interesting and really nicely defined paper because what they did was they actually randomized patients to a variety of different arms. They looked at CT, they did all patients that were borderline resectable and locally advanced, and they followed them with CT or PET MRI. And then they did very robust texture analysis, RECIST, and a variety of different other metrics. They saw a variety of different areas under the curve, but at the end, the story was that in borderline resectable or locally advanced patients, let's move that there, they saw changes in tumor metrics in both CT and RECIST, but more importantly, that changes of SUV, meaning the glucose avidity, were actually predictive of response. And that's exciting because that can be done everywhere, right? You don't need a PET MRI. They did it with PET MRI, but you could do it with PET CT. And so that may be an area where we want to re-engage in some of these trials because PET CT is ubiquitous. There's lots of PET CT trials going on within SWOG and ECOG-ACRIN and other consortia. But I think the most exciting area is these new agents, FAPI being the best one that I've seen, at least right now. There's gallium-68 FAPI, or it's another cousin, there's an FAP, are all basically ligands that are specific to cancer-associated fibroblasts. And I'll end with this really provocative, these slides that are really quite telling. This is a patient with pancreatic cancer. Here you can see uptake in the cancer itself within the head of the pancreas. You can see some nodal disease here in the retroperitoneum and also in the hilum. But more importantly, they really saw, at least the group that invented this, saw that this was extremely sensitive to peritoneal disease. And so just as a change in the standard of care, if we could save these patients laparoscopy, that's a huge change. That's a change that you'd want today. They did a head-to-head comparison in comparing FDG to FAPI, at least in their patient cohorts. They saw that FAPI outperforms FDG in the tumor itself, in nodal metastasis, liver metastasis, and carcinomatosis. And so from all of those, it's a really exciting molecule. I think everyone's trying to get their hands on it these days. And so there's a lot of interesting science to be had there. We have a PET MRI. We're excited about it at OHSU and playing, a variety of different things. We are using it to sort of ask questions in Dr. Lopez's what we call his switch trial, which basically randomizes patients into either gemcitabine or FOLFIRINOX, but asks the question if there's no response or if there's progression, you can kind of switch midpoint. But it's exciting to kind of look at potential biomarkers that may actually reflect those changes and predict those changes so that we wouldn't, we'd have better changes of better assessments of therapeutic response. So this summarizes kind of, this is an article and this is in the, in the record, but this is an article that, from Abdominal Radiology that sort of summarized where we were about 2 years ago in the studies for therapeutic response with imaging. And they were summarized with what I said. Essentially, in the PET world, SUV basically is telling a better story than it used to. I'm sorry. Diffusion-weighted imaging changes in the apparent diffusion coefficient tend to actually tell a better story. The challenge there is MRI is not as utilized as heavily as CT. And the texture analysis story is early, provocative, but needs some work. And then other potential early biomarkers like FAPI and other things. But at the end of the day, what we need to, as radiologists, to do for you is to make imaging a better assay. And what we do there is what we need to do there is understand all of the sources of variance so that it tells you when the problem is there, you know what the variance is, so you can basically say, I know when to treat or not when to treat. So, in summary, from my perspective, the lack of radiomics is here to stay, is improving every day, but I think more preliminary work is needed because you need to understand the knowledge and sources of input heterogeneity, the variance, phantoms for calibrating our devices across sites, and then the high quality data that I think you're getting in ECOG and SWOG, I think is actually quite helpful because that heterogeneous input will tell you where your radiomic signatures are actually good and bad. And I think the story is early, but I think it's going to be very robustly told with something like FAPI. So thanks very much. I think I overstayed my welcome, but I'm happy to answer any questions if there's still time.
Oh, no, that was fantastic, Alex. Thank you. I mean, I certainly have a bunch of questions, but I know where to find you in your dark room. But wonder if there's any questions here from the floor or from any of our virtual attendees. Please just unmute yourself and jump in. Sepp, go for it.
I have a question. Thank you so much. That was fantastic. We discussed this morning a bunch of sort of clinical trials in neoadjuvant space for colorectal cancer. What do you think would be like the best way if we were to incorporate like imaging? What is like sort of the minimum that you think, we should incorporate for future trials in order to like use it, for secondary analysis? And because I understand like a lot of these are not necessarily ready for, and validated enough that we can use really as obviously like primary endpoints, but even as exploratories. I'd love to hear your thoughts about that.
That's a great question.
Oh, oops, that's me. That's me. Yeah.
Okay, sorry. That's a great question. I mean, it's very funny. I was in the imaging group this morning with Dr. Knopp, and it's very, I hadn't been involved with Akron in a long time. And when you put on your science hat, it's much different than the challenges that the cooperative groups face, because it's not that it's not essentially scientific rigor and the focus of the question that's the only germane question here. Is enrollment is key. And because you want to get your statistics helpful to answer the clinical question. So that being said, you're challenged by what you can deliver because of the heterogeneity of devices and radiologic assessments that you have at your fingertips, so to speak. That's what's so exciting about radiomics, because at the end of the day, so much of that data is CT rich, right? And so I would say that continue gathering the CT data, because as you gather more, you will get more robust retrospective assessments that may provide insight into radiomic signatures that are then prospective hypothesis-driven trials. I'd say one. In the colorectal space, I always liked MRI just because there are so many different questions that we can ask, right? And we use a lot of, just in the standard of care, we use EOVIST MR a lot. We looked at we've asked the question, whether or not changes of diffusion predict response, and diffusion being present or restricted diffusion being present seems to be a really sensitive way of assessing disease burden a lot of the times that far outweigh things like CT. And so it does change management questions as well. So I like MR, but it's not, and even standard of care MRI is fairly helpful. Quantitatively, MRI is really challenging to make ubiquitous and standardized across the board.
Great. We have a question, David?
Yeah, so actually related to that last point that you made.
Yeah.
One of the charts that you showed indicated that for a few of the studies, ADC pre-treatment actually correlated well with R0 resection, right?
Yeah.
And I'm wondering what your thoughts are on using that to predict patients or identify patients who might benefit from intensification of local therapy. I know that for the locally advanced setting, right, and borderline resectable, we're really focused on systemic therapies, but whether we could identify a cohort that might benefit from radiation, for example.
I don't think, but I don't think that that's been prospectively asked. It's a great grant idea. The challenge in diffusion in the upper abdomen is reproducibility with all of the gas and motion. That's been, the vendors have played a large role because they saw the benefits and how diffusion was essentially selling devices, because it's such a really great tool to see things. So it's really sensitive, fairly specific, quantitatively rich. But the challenge is that if you have a gas-filled, highly motion-rich, and I'm not sure I'd rely on the tiny pixel. If I did a texture analysis, for instance, and a pre-post, I'm not sure I could meld those two without having some level of artifacts. But it's a great idea. I would certainly do it I would do that trial in an animal first, and then translate it up to see what the error bars are, like they did, like Bob Gillies did.
Yeah, really interesting. Thank you.
Yeah.
Well, Alex, that was wonderful. I think we do have to move on to our scheduled presentations, but again, I think hopefully you'll maybe be here at the end of the session. We can answer a few questions from the floor. All right, our next presenter is going to be Dr. Jonathan Sham from the University of Washington. He'll give us an update on his proposal on lenalidomide for pancreatic fistula. Jonathan.
Thanks so much, Flavia. Are you able to see my slides?
Yep.
Great. Good afternoon, everyone. I'm Jonathan Sham. I'm one of the HPB surgeons here at University of Washington. Sorry I can't join you in person. Like several of my other colleagues on the line, I'm stuck in quarantine. We're just going to be here giving you an update on our proposal for lenalidomide for the prevention of postoperative pancreatic fistula. The only disclosure is that Ipsen Pharmaceuticals funded the phase 2 trial that I'll just go over briefly during this presentation. Just for any non-surgeons in the room, just to let you know what we're talking about, pancreatic fistula or pancreas leak is leakage of enzyme-rich fluid from the cut edge of the pancreas during pancreatectomy that can cause multiple downstream effects, including bleeding, delayed gastric emptying, infection, reoperation, and even death. Rates are variable throughout the literature, but most recent large meta-analyses peg them somewhere between 15 to 25% for Whipple and 20 to 30% for distal pancreatectomy. And despite multiple various trials, really nothing has stuck over the past 3 decades as far as being able to reduce these rates. When it does occur, it almost doubles the cost of pancreatic resection. And if you kind of extrapolate this out to the pancreatectomies performed in the United States each year, it leads to tens of millions of dollars in increased healthcare costs. And then what we all care about, survival of the group at MGH, took a look at when postoperative pancreatic fistula occurs. It's actually the single biggest predictor of decreased overall survival, more than nodal status, R1 resection margin status, showing median survival of 17 months for those who developed a fistula and 34 months who did not. So based on this, our group performed a single-arm phase 2 prospective study in evaluating a single dose of 120 milligrams lenalidomide given preoperatively to look at the outcome of clinically relevant postoperative pancreatic fistula. This is the ISGPS grade B and C you may be familiar with. As many of you may know, lenalidomide is a long-acting somatostatin analog. It achieves a peak serum half-life in around 7 hours and lasts for about a month. And we enrolled about a little over 100 patients, 98 patients completed the study. In the Whipple group, the clinically relevant postoperative pancreatic fistula rate was about 11%. And really astonishingly, in the distal group, 2.7%, only a single patient had a grade BC fistula. So when we initially proposed our schema, we wanted to recapitulate the phase 2 design. So essentially we had a Whipple arm and a distal arm, both with and without lenalidomide and placebo. And we got feedback from the in-court executive committee and from statistical review with Catherine Guthrie that, from a feasibility standpoint, 500 patients probably wasn't going to cut it. And so after some back and forth, we actually settled on just doing a distal pancreatectomy study. The thought being that given this is where the effect size was most significant, we could obviously decrease our numbers. And also the thought that, well, if we don't see any signal in the distal group, the likelihood that we'd see one in the Whipple group was quite low. And so again, the currently proposed plan is about 180 patients with 90 in each arm. The primary outcome, again, is grade B, C fistula with secondary outcomes of DGE, biochemical leak, hemorrhage, time to initiation of chemotherapy, and hospital length of stay. I did highlight a couple in red, and that's this change in skeletal muscle index, as well as these promised quality of life measures. These were introduced by our colleagues in the Palliative End of Life Care Committee, Dr. Robert Krause, who I believe is in the audience there with you now, and really, I think, help enrich the study and is going to make it even higher impact. So again, update where we are. We have, again, initial encouraging support by the NCORD Executive Committee. I submitted this for the Coltman Fellowship. Unfortunately, did not get that, but we can resubmit next year. The real hangup for us right now is that Ipsen, the company that sponsored the phase 2 study, unfortunately has notified us that they're unable to support the phase 3 study, despite kind of previous assurances. This is because a recent generic formulation came on the market a couple months ago, and they feel that essentially it's not worth their while to do that given the presence of the generic. So we're doing our best to reach out to the generic company, but are having some difficulties. So if anybody knows anyone at Cipla Pharmaceuticals, please let us know to see if they would play ball with us and help get the study going, because even the generic is around $6,000 for a single dose. Again, thank you again for the SWOG Surgery Committee, Palliative End of Life Care Committee, my mentors, Vena Pillar-Seti, Gabby Curian, and Robert Krause, as well as Catherine Guthrie and Sufan Wong, who's been really instrumental in helping us refine this. And again, welcome to Seattle.
Great. Thank you, Jonathan. We have a question from the floor.
Hey, Jonathan, very nicely presented, and congratulations on the work so far. With the increasing number of patients getting neoadjuvant treatment and the decrease in post-op pancreatic fistulas that we see with neoadjuvant treatment, is there any thought about stratifying those patients within your trial?
Yeah, it's a great question, and one we've kind of struggled with early on. In our study, about half of the patients who got resection for PDAC got neoadjuvant therapy. We actually didn't see a decrease in the efficacy of lanreotide in that population, for whatever it's worth. But again, it's a small sample size, single arm. There was some concern that given that we're now down to just a distal study, the role of neoadjuvant is, again, more limited in that subgroup, as you are aware in many cases. The limiting of just including non-neoadjuvant patients, again, may also hinder feasibility as well. But it's a point very well taken.
Quick question. Dr. Sham, great presentation. Just a quick clarifying question. In terms of the division of the pancreas itself, does the method of division of pancreas, are you taking that into account if stapler reinforcements like SeamGuard is used versus not? Is it a Bovie transection or a stapler division and so on? How do you account for those methodological differences in division of pancreas and the leak rate?
It's a great question. And again, every meta-analysis available would indicate that the method of transection, whether it be stapled, reinforced, or not, hand-sewn, does not make a difference on the incidence of CR-POPF. We also want to make this a pragmatic study as much as possible, and understanding that, like at our institution, we always use SeamGuard, we always use stapler, but we know many institutions don't do that, and we want to make sure this is applicable to as many institutions as possible. And so, given that, I'll say, unclear effect of the type of transection on the rates of POPF, we didn't feel it important to really write that into the protocol and dictate that you have to divide the pancreas one way or the other. I will say the one thing we are doing that we struggle with a bit, but I'm becoming more and more comfortable with is mandating leaving a drain. Again, we pulled a lot of places. There are some places that only selectively drain, but due to the evaluation of grade A leak or biochemical leak now it's called, we did feel that mandating leaving a drain would be important. And again, most people are doing that anyway, is our understanding.
Yeah, no, I agree, Jonathan, with that, especially given that we have a trial that says, if you don't drain a Whipple, at least you're going to have more problems. I think the biggest issue, I love the proposal. I love the fact that you're running it. Dr. Krause has helped through the NCORD system, but you're going to have to find a solution to the drug problem, the lanreotide. So yes, certainly, we'll try to kind of help out with that as much as possible, but that needs to be sorted out before we can really move forward. Thank you. All right, we'll roll into our next presentation. Who I believe, we pull up the agenda, is going to be Dr. Golami. Oh, sorry, yeah, Dr. Golami talking about total ablative therapy for patients with limited metastatic colorectal cancer.
Great, let me just share my slide. I'm really amazed how Flavia somehow did not get this disease. So I just have to really like say that out loud because every surgeon I know is like literally infected.
We were all thinking it.
Anyways, I appreciate you guys giving me this opportunity to present this trial that we basically are doing in collaboration with Alliance as well as NRG. So this was a concept that came out of Alliance and NRG, and then I was asked as a virtual chair to participate and then also in this champion for that. So just to give you guys a little bit of a background is that, metastatic disease in terms of for colorectal cancer, when we know that we resect liver or lung metastases and we see increased survival in various studies. Here to the left is shown in trial where metastasectomy surgically were performed for lung and liver only disease that shows a clear separation between the survival curves. And then on the right, it's the ERTC study that also showed very similar studies results from in the unresectable disease setting, where basically it was a combination of surgery and RFA used, showing an increase in survival. When you then further look at in terms of a total ablative approach, there was a single phase 2 trial looking at tumor agnostic tumors. This included 99 patients, and of which only 19 were colorectal patients, but still, regardless, it showed that using essentially a total ablative approach, using stereotactic ablation therapy showed increase in PFS as well as OS for patients with oligometastatic disease, including colorectal cancer. And so the overall survival here showed a big difference with a hazard ratio of 0.5. Now, with that in mind, with the first two studies that I mentioned, there's also other multiple other NCTN clinical trials, including with breast, as well as lung and esophageal, that are using a very similar approach, where we now are moving forward with sort of like using a total ablative approach of all metastatic lesions. And we noticed that, really with the off protocol use, this has been like sort of like rapidly expanding. So, however, the benefit has not been really 100% proven, and the potential toxicity is still, fairly a concern. So I think, therefore, it's really a good time to answer this question that is really currently undefined in the colorectal setting, despite what is happening in the community. So therefore, the hypothesis of the study is really using a total ablative approach of all visible disease after 4 to 6 months of systemic therapy with of all in colorectal cancer would improve overall survival. And just FYI, like when I say a total ablative approach, I include stereotactic radiation plus resection plus an ablative and microwave or RFA ablation by radiology or the surgeon. So who is the study? Eligibility essentially includes all patients with colorectal cancer except for patients with MSI high and BRAF mutations. We are excluding any patient with metastatic disease to the brain, peritoneum, or mental metastases. The primary tumor needs to be resected at least 12 months prior to this trial, and also like any patient who has had prior adjuvant therapy needs to be at least 12 months out of that. We need the inclusion also includes less than 4 metastatic sites on the preoperative imaging scan that I will go over on the schema, and patients with liver-only disease are not included just because we are moving forward with a potential pump, and we did not want to have any overlap with that study. So with regards to the definition of the metastatic sites, here just like shown here so that you guys get an understanding, a single site includes either each lobe of the liver, each lobe of the lung, each adrenal gland, and then lymph node basins that are amenable to resection or a single Saber field. Now for resection, we're only allowing the portal lymph node since really there are no other metasectomy of portal lesion of lymph node metastasis is really part of standard of care. And then bony metastases are, which are amenable to a single Saber field as well. So here's the schema that you can essentially, it's like see in one shot. So here's patients with newly diagnosed metastatic colorectal cancer, again, less than 4 sites of disease based on the initial imaging, with the primary tumor being resected, while BRAF and MSS, BRAF wild type MSS tumors, and no liver only disease. These patients then will undergo systemic therapy of 4 to 6 months. And then clearly those who will progress, they will just be off protocol. So they will be re-imaged, and then based on those criteria, again, if they are included and meet eligibility criteria, will then be randomized into a control arm, which consists of standard of care chemotherapy, and that is at the discretion of the medical oncologist, versus in the experimental arm, it will be a combination of standard of care chemo plus a total ablative approach of all metastatic disease until progression. The stratification points are listed here, where we are looking at the number of metastatic sites. This is very similar to that phase 2 trial that I mentioned before. They did it very similarly. It was less than 5 sites, so they did less than 3 and then 3 to 4 metastatic sites. Timing of metastatic disease in terms of de novo versus, a secondary metastatic disease. And then also, whether lung and liver would be a yes or no in terms of the metastatic lesions. With regards to the primary endpoint will be overall survival. So this is a phase 3 superiority design and then I'll go over the statistics on the next slide. And then we do have various correlatives, including circulating tumor DNA and some other markers. With regards to the statistics, this will be a phase 3, as I mentioned, with a primary endpoint of overall survival with a 1-to-1 randomization. Including essentially the null hypothesis comes from the Dr. Vinook's study in the metastatic setting, using a median overall survival of 26 months for the control arm. And then with really the projected enrollment of 398 with 346 evaluable patients and the dropout of 15%. And this is essentially what the statistics come out to be. With regards to the secondary endpoints, we're looking at progression-free survival, adverse events, quality of life, proportion of patients really completing all the total ablative therapy, time to local recurrence, as well as the ctDNA progression-free survival. And with that, I take any questions, and I now have a few questions for the audience.
Great, thank you, Seb. I had one question. So when you say the total ablative therapy, so it can be a mix of whatever those therapies are, as long as all sites are treated, correct?
Correct. So the way so we're working on the details of the protocol. So interesting enough, I found out just 2 weeks ago that they're very, very similar, but phase 2 study is currently undergoing in Australia. So we just had a first meeting in them, and unfortunately I missed that meeting. But when I spoke with Eric, who is the lead on this current study, is essentially this design is like exactly the same. Theirs is only just a smaller study, obviously being a phase 2, and I was curious in terms of which disease do you treat first, right? Like, I mean, if you're dealing with lung, liver, let's say some bone mets, I'm just making up a scenario. There's various sort of iterations of it. The way I thought about, and the way we should be writing it in the protocol, is like at least start with the liver, since we know that really like probably controlling the liver is the most important thing for this disease. But the exact, sequence and how exactly it's done, will be really at the discretion of sort of treating physicians. We are, with regards to surgery, we're only allowing lung and liver, which is standard. And you can use a combination of ablation plus resection, which is, again, standard of what we do in the liver anyway.
And portal lymph nodes, I think you mentioned.
Correct.
Yes. Now, what if you find additional disease? Do they fall out then? Let's say you find 6 lesions.
You mean you open up and...
Yeah.
Yeah. Yeah, but I think honestly, with the day imaging these days, I mean, and like unless you get a really crappy CT, you shouldn't really find too many new lesions. Yes, I think the issue remains. I personally would love to, make MRI as a standard, but I think that just is too much to ask for this kind of large study, and I think you would fall into like too many protocol violations. But yeah, technically, you could still treat it as long as it still pertains to one lobe and you're not changing the number of mets. You know what I mean? I find it very hard that a patient becomes eligible for the study.
Well, I have, Alex was right here next to me. When you mentioned the imaging, I don't know if you had any comments about finding.
Yeah, I mean, I would love Alex's thoughts on this.
I mind the microphone.
Yeah.
No, but I guess if I was to look at that data, though, how do you separate those sites that had maybe single contrast CT from an MRI site that found more disease? Aren't you biasing the data by the site that actually that is more sensitive to the disease? Or is it?
So we will require at least a full-face CTs versus an MR. That's an
Okay. Okay.
I don't think. I honestly, I think yes, a single-face CT is not going to be
Right. Yeah, I mean, I guess if I was to sort of think about that study from a science perspective, I probably would go with trying to at least use the CT data as the baseline denominator, right? Because the MRI is going to confound your data. But yeah, it would be nice to have EOVIS data on everybody.
I would love that. Yeah.
Yeah, exactly. Well, we'll get there one day.
Maybe we get enough to do a sub-analysis, honestly. I think.
Yeah.
But I think
All
with
right.
regards to Flavio's question, I doubt, since we're really doing each lobe as a site, even if you had one or two more lesions in each lobe, it probably wouldn't make someone eligible. Obviously it could, but various scenarios can pop in my mind, but hopefully that's a very small number of patients.
Got it. Well, thank you, Sep. So our next speaker will be Dr. Borisens. It says it. Did I have the wrong thing? I might have the old agenda. Is it Maggie now?
Yeah.
Yeah. So Dr. Sentel from UCI.
I guess you'll advance my slides. I'll let you know as to when to advance it. Thank you very much. Yeah. I don't want to. All right. Well, thank you again. Thank you, Dr. Roca, for the opportunity to present. This concept that we are presenting was actually presented earlier today at the GI committee, the closed working group committee. This is a protocol that myself, as well as Dr. Smitha Krishnamurthy, has been working on for quite some time, but we are bringing this back as some of the data from the randomized control trial, which is the Foxtrot study, as well as the niche results, are more mature now, and I think it is the optimal time for us to be discussing this concept. And the premise of the concept is use of preoperative chemotherapy with or without immunotherapy in patients with microsatellite stable colon cancer. And I will go through the rationale and our trial design and would like to get some input on that. Next slide, please.
I just want to make sure, are our virtual attendees seeing the slides?
Next slide.
Not yet.
Oh, clicker? Oh,
Oh, no, I
okay.
can use the clicker.
Yeah, but our virtual attendees don't see the slides, because I'm actually the slides are only being shown here in the room. So let's hang tight for just a sec till they get it.
Sure.
I'm not seeing them. Yeah. Mm-mm. Yes.
Yes.
Great.
Yes.
Go ahead, Mike.
Great. Excellent. So the idea is, for patients with T4 as well as N2 colon cancer, there's still a lot of room for improvement, is because when we look at the 3-year disease-free survival for patients with T4 or N2 stage 3 colon cancer with FOLFOX or CAPOX, it is only about 60%. And similarly, for patients with high-risk stage 2 colon cancer with adjuvant FOLFOX or CAPOX, the 5-year disease-free survival is about 74% for T4 compared to 87% for T3 cancers. Now, when we look at the SEER data, again, the 5-year relative survival for T4A as well as T4B, for T4A is about 80%, and for T4B it's about 54%. Certainly, T4 colon cancers tend to have, poorer survival, earlier recurrences, and there is a lot of room for improvement. And same thing applies to some of the higher node positive cancers. Next slide, please.
And can we get a
Oh, yes, I can do it.
We have it it's in the notes mode.
So this is the Foxtrot study. Obviously the results of this study is now available. It's a large randomized controlled trial that looked at preoperative chemotherapy in patients with T3, T4, N0 to M0 colon cancer that is resectable. And the patients actually were randomized to the standard of care. Standard of care is surgical resection followed by 24 weeks of FOLFOX. And in the experimental arm, patients were treated with 6 weeks of FOLFOX, followed by surgical resection and another 18 weeks of FOLFOX postoperatively. That's the pre and post-op combination. In this particular study, the key observations, yearly observations, were that there was no increase in perioperative complications. There is decreased risk of undergoing surgery without achieving R0 resection in the group that received the pre and post-op chemotherapy, 4.8% versus 11.1%. Mainly this benefit was seen in the microsatellite stable cancers or MMR proficient cancers. Now at the bottom, did it go away?
Yes, it did. My apologies.
Yes. This might be the charm. We'll get there. The graph that you see on the bottom part of the screen is about the risk of recurrence or the 2-year recurrence events. As you can notice, I don't know if I have a pointer. So as you can notice, the red line is the pre plus post-operative chemotherapy, which is the experimental arm, had lower 2-year recurrence events, 16.8% in the experimental group compared to 21.2%. Now, this is a very important result, is because it once again shows that the evidence or the number of recurrence is lower in patients who are getting the pre plus post-op therapy. Now, the authors went ahead and showed that there is a correlation between the tumor response and the long-term oncologic outcomes. I'll unpack this. Next slide, please. Oh, I got it. So I'll unpack this slide a bit. So here what we are seeing is the tumor regression scoring, which is graded from 0 to 4 based on Dworak's regression grade. So 0 being no response and 4 being complete response. And in patients who had complete response, 0 out of 19 patients with MMR proficient tumor had a complete response and they had no recurrences. And as you can see here, in the no response group, 151 patients had no response, and 58 of those patients had evidence of recurrence. Again, about 38% of patients who had no response had recurrence here. And in patients who had mild response, 56 of 274 patients, that's about like 21% of patients who had recurrence. So the tumor regression grade actually matches with the, or at least correlates with the recurrence that we are seeing. Now, okay. Now, what is so that is the data that we have for preoperative chemotherapy. So what data do we have for immunotherapy in this group of patients? So there are a couple of clinical trials that I want to highlight here, but I also want to bring our attention to the immunoscore. Now, this is an important paper that was published showing the role of immunoscore, which is different from just the microsatellite proficient status, because the immunoscore, or high immunoscore, was seen in about 21% of stage 1 to 3 colon cancers. Now, we know that the microsatellite instability or MMR deficient tumors, we say it's about 5 to 6%, but certainly the immunoscore high tumors are of a higher frequency in stage 2 to 3 colon cancer. Now, 2 clinical studies that have looked at the role of immunotherapy in patients with early stage colon cancer, combining both MMR deficient and proficient tumors. So we have Nicole study, which looked at nivolumab, 240 milligrams at 4 and 2 weeks prior to resection. There was evidence of response even in microsatellite stable or MMR proficient tumors. And then the most important study that we want to highlight is the NICHE study, which looked at ipilimumab, which is and the nivolumab, CTLA-4 inhibitor, and the PD-1 inhibitor combination. And patients who had MMR proficient tumors also had pathologic response in this study. And what was important to notice that the CD8 and PD-L1 positive cells, that correlated with the response. And this is what we are trying to really kind of exploit when it comes to this combination therapy. So what is the rationale for neoadjuvant chemotherapy plus immunotherapy for microsatellite stable colon cancer? Now, we are very familiar with microsatellite unstable cancers and the use of immunotherapy. But there is a real possibility here, is because I want to highlight the preclinical data, which is in a mice model, FOLFOX, when it was administered in mice bearing colorectal tumor. There is induced myeloid-derived suppressor cell depletion was noted, as there was increased infiltration of TILs, and also increased interferon gamma secretion. And this TIL infiltration also correlated with the PD-L1 expression of the tumor cells. And when we look at what is the human data, the figure or the picture that you're seeing to the left of the, to the far left of the screen. So what you're seeing here is the liver metastasis before and after chemotherapy in about 9 patients. But what they were able to highlight is that the PD-L1 expression, LC3B, which is an autophagy marker, as well as CD8 infiltration, significantly increased after the FOLFOX treatment. And based on the preclinical data, we know that this event actually occurs very early, right after the chemotherapy. Within about 7 to 8 days is when the peak effect is seen. As you know, this is both infiltration of the lymphocytes as well as the PD-L1 infiltration. So there's tumor suppressor kind of activity. And so the tumor is primed for immunotherapy effects when there is both CD8 infiltration and PD-L1 expression by the tumor cells. So now what we have is that, we know that chemotherapy in the T4, T3 colon cancers, microsatellite stable colon cancers, tend to have reduced, or at least has shown to now have reduced recurrence in 2 years. We are also seeing some response with immunotherapy in microsatellite stable colon cancers. We have enough preclinical data to justify that there is change in tumor microenvironment, especially immune microenvironment, that could prime the tumor for combination immunotherapy with chemotherapy. So there might be a possibility to use this combination in microsatellite stable colon cancer. So with this in mind is how we have designed this randomized clinical trial. So this is, the eligibility is for patients with T3 with node-positive colon cancer, or T4, any node without any metastatic disease, left-sided and MMR proficient right-sided tumors are the patients who will be eligible. Obviously, the patient should be non-obstructed or could have undergone a diverting ostomy to alleviate an obstruction, because sometimes patients with T4 cancers could present with an obstructing tumor. And the first 10 patients, so the randomization schema is 1-to-1 randomization. Patients will receive either 3 cycles of FOLFOX. In the experimental arm, they will receive 3 cycles of FOLFOX with the ipi-nivo on the first cycle and just nivo on the second cycle, which is exactly what the NICHE regimen is. And so we are just following the NICHE regimen here, and then followed by surgical resection. And then post-operatively, patients will be expected to receive at least 6 weeks of FOLFOX or Kpox. And there are several correlative studies that have been listed here, ctDNA, immunoscore, and so on. But the most important thing is safety, right? What is the safety of this combination treatment in this group of patients? And that's why we have a safety lead-in, where the first 10 patients will be enrolled in the safety lead-in, and we will monitor the toxicity before enrolling additional patients, particularly during the first 30 days post-op, before opening up for the rest of the study. And let me go on to the next one. Our primary endpoint here, we chose tumor regression grade as our primary endpoint because what we are trying to understand is that if this combination improves the response. And so we used that tumor regression as an endpoint 1 to 4, which is any response versus no response, is our primary endpoint. And the secondary endpoints are shown there, toxicity, delay in surgery, as well as 2-year recurrence-free survival. And there are also other exploratory and correlative studies that are exciting, definitely for me. And in terms of the number needed for this particular trial, this is how we extrapolated the information that we have thus far. So we looked at the response rate for Foxtrot, as well as what was the response reported in NISH. So there is a possibility that combination could increase the number of responders, which is the first way that we have calculated the statistical analysis. So if we use the primary endpoint, tumor regression 1 to 4 versus 0, which are responders versus non-responders, we would need 50 patients per arm with a two-sided alpha of 0.1 and 80% power. But however, if we look at the depth of response, if we believe that the deeper, the combination will actually provide more patients with complete to moderate response, and we compare 2 to 4 versus 1 and 2, we will need 76 patients per arm, again with the same statistical power, enrollment of 167 patients. So, this is our proposal. I'll go back to the schema itself. Couple of things that have been done in terms of feasibility is we did do an ASCRS survey, polling a lot of community colorectal surgeons as well, and a lot of them expressed interest in terms of treating patients with preoperative therapy if they have T4 or T3N1 colon cancer. So it seems like this is an acceptable, definitely therapy, particularly with the results of Foxtrot showing that there is an advantage in treating these patients with preoperative chemotherapy. I think there will be less hesitation in considering this option for patients with microsatellite stable colon cancer. I'll be happy to take any questions.
Great. Thank you, Maggie. Again, I'm going to lean, since I have Alex here, because we usually don't have this benefit, is there was something that was brought up about how to accurately, do the clinical staging for colon cancer based on films. I'm just wondering if Alex has any comments on that.
Well, for rectal cancer, that's...
But this is for colon cancer.
Yeah, I know.
Yes.
So how do you feel about the reliability of, because that's what Foxtrot used?
Yeah, Foxtrot actually did a very detailed study prior to even using CT to enroll patients, and they found that their sensitivity is about 95%. So they had radiologists and they looked at several images. So the chances of overstaging T1, T2 is extremely low in their group, and we are going to follow exactly the same methodology for this study because it's been already done and it has been shown that it is effective. And the number of patients, even in Foxtrot, their sensitivity is very, very high.
So you're saying Alex can't say MRI, he's got to stick with CT?
I think CT actually is more universally used in the upper colon.
Yeah. And with all the, CT is probably going to be the common staging procedure or staging scan that's going to be done for patients with colon cancer. So we want to just follow the same methodology as Foxtrot. And then central review of radiology and pathology is something that we are going to be doing if we move forward, yes.
Yeah, I think, again, this is great because this really follows up on the work of Foxtrot, follows up on the niche trial. And I think, as you had hinted, I think we as a surgery community will need to really kind of beat the drums on this and get the study out, hopefully, and then get it accruing, because I think it makes sense, right? Most of GI oncology is moving towards the neoadjuvant space. As you said, the trick is always what's the inclusion population? Because I know this study has kind of gone back and forth between T3, T4, N1, and 2.
I'm glad you're bringing up this point. Foxtrot had T3, T4, N0, N2, and then M0, right? The reason why we changed it to T3, N1 was the concern that some that there might be a concern about over-treating patients with preoperative therapy. And that is why we said that for T3, it has to be N1, but for T4, NEN, because T4, in the T4 area, it is just well accepted that the patients would probably get preoperative therapy. Yeah.
Quick question. Any input from patient advocates on this? I mean, I can see having resectable disease, there's a very strong bias for patients to just have it taken out.
Yeah, we have had some preliminary discussions, but we are also, Dr. Krishnamurthy and I are going to have even a more formal discussion based on the feedback that we receive with them, but also going to be presenting the Foxtrot data as well. Yeah. But thank you.
Perfect. Thank you,
Yep,
Dr.
thank you.
Menkel. Appreciate it. So our next speaker, just to try to keep us on track a little bit, is Dr. Bor Sansi from Honor Health and TGen. He'll talk to us about neoadjuvant, gem, nab, cis, paracalcitol, nivolumab versus FOLFIRINOX.
So thanks, Flavio, and I really appreciate the invitation. It's an evolution and work in progress, and what was the initial interest too was to bring what's known now as GAP to the locally advanced population of pancreas cancer, but that's actually made NCCN guidelines a couple months ago, which is great. And one of the discussions that came out was from the committees, from the Pancreas Cancer Committee, was to bring up our combination study in stage 4 pancreas cancer that takes GAP plus paracalcitol and nivolumab. So are the slides, okay.
Looks like they're making their way up.
So,
They were up for a second.
yeah.
Actually, they're up virtually.
Oh, okay. Okay, so I can advance through.
Yeah.
Okay,
Use your clicker and then you can use.
okay.
Radiologists are very generous.
That's right. Alex, thank you. For pancreatic cancer, we had looked at gem, nab, paclitaxel, cisplatin, and metastatic disease, and published this a couple of years ago. We saw that, let's see, there was a 71% response rate, and we actually decided, further built upon this. Looks like there's things are working okay, but thank you. So we further built upon this through our collaboration through Samhsa Cancer. This came from Mara Sherman, who's now at OHSU, when she was a postdoc and looked at vitamin D analog therapy and causing global changes in pancreatic tumors. And so the decision was made that let's take a look at vitamin D analog therapy, especially as it affects the tumor microenvironment, and add a checkpoint inhibitor. To date, prior, very limited efficacy and very questionable add-on with nivolumab or checkpoint inhibitors with Gem-Abraxane-based combinations. So we took the, maybe I do need your, can we advance one more slide?
I think it's on there. I think it's a very
Is it the,
It's the one on the right, that one.
this one right here? Okay.
No,
Yeah, it's,
maybe that one.
no. Is it the, it's not the red one, is it?
No, the red one's the laser point.
Okay. Are you able to advance it manually? Yeah, if you can just get to the next slide.
I'm sorry, is this a Horowitz one, sir?
No.
No.
Sansi.
Okay, there we go. Thank you. So, so this is a metastatic disease. We had presented this at the AACR Pancreas Cancer meeting in the fall last year, and what we saw was an 84% response rate in stage 4 pancreatic cancer with this combination. Next slide. The summarization, as far as the data is displayed here, we saw an overall median overall survival of 19.2 months. And a CA19 normalization rate of 38% for those that did overexpressed 19.9. So next slide. So after discussions, the feedback was exploring this further in the locally advanced disease population in pancreatic cancer, and again, this is still remains a work in progress, but the proposal is looking at that combination that's based upon the GAP regimen with nivolumab and paracalcitol in comparison to modified FOLFIRINOX in locally advanced pancreatic cancer. Next slide. We can go to the next slide. So the primary objective that currently and certainly open to suggestions is looking at progression-free survival with secondary objectives with overall survival, resection rate R0, and then did not plan this, but it's great that we have a great radiology lecture this afternoon with Radiomics. We have a colleague at Imaging Endpoints, Ron Korn, who is very interested in exploring this, but again, as more of an exploratory objective. And then also looking at tumor tissue through basal and classical subtypes that's been established from Jen Genier's lab at UNC, and also collecting peripheral blood at baseline and throughout the treatment itself. Next slide. Again, I think radiomics is a very interesting field, and again, looking at CAT scans from a feasibility perspective. Beyond that, again, I'm not sure if we would put in extra imaging, but certainly open to looking at PET scans and on top of that too. Next slide. With looking at progression-free survival, there's a lot of data that's varied with the LAPC and with FOLFIRINOX. It appears that 8 months tends to be a relative standard across the board, and looking to improve that in a significant way with a different combination comparison is the basis for this proposal if we're going to look at PFS. Next slide. And that's all I have. Thank you.
Great. Thank you. Any questions, Dr. Borisensi? So my first question is, you need a catchy name for that 5-drug combination.
Right,
because
yeah.
right now, it's too much to write on a slide.
Yeah, yeah.
But I'm just curious, because, I mean, I guess you gave me the perspective as far as this is something that the NCCN has already put in there. But what was that based on, that they already put the GAP regimen on?
Well, yeah, it's not a category, it's a 2A.
Yeah.
The current stage 4 study, I suppose, I wasn't in those discussions, but I suppose the basis was taking something that could be effective for very advanced disease and bringing it a little bit, to locally advanced. With that being said, I think that looking at, and we had a great talk earlier this morning in the GI group about chemotherapy really causing this induction of and sensitivity to immune therapy, and exploring that a little bit more in an earlier stage disease is also another appealing aspect too.
Because I think, what we would love to see, and again, not that this is a surgery committee, is we looked at, as conversion therapy or resectability, these tend to be very subjective endpoints, so they're not the best.
Right.
But will that be something that's part of this? So will patients will you compare that, I guess, as part of?
Yeah, I think those are secondary endpoints, and I think, again, even throwing out PFS, I think locally advanced, and Alex highlighted this too, I think it's a challenging, pancreatic cancer in general is challenging to go by traditional ways of measurement. So even utilizing RECIST, and that's why I just don't think we can do that for locally advanced disease. And so, again, to me, that's part of an evolving primary endpoints, looking at whether it's disease-free. The other thing to consider is perhaps even event-free to capture some toxicity differences too between these regimens.
That's the other thing I was going to mention, is that if you thought about composite type endpoints, so folks that either fall out due to toxicity, fall out during progression, or perhaps get taken to surgery and then metastatic disease is found there.
Right. I think that could encompass all of those challenges for absolutely.
Perfect. Any questions from the floor or anybody online?
I have a question.
Yeah.
The vitamin D sort of modulates based on Mira's data, the tumor microenvironment. Did you guys think about using something like losartan based on the MGH data, sort of to give it a head-to-head? Because you had potentially, some people say, some collagen disruption from vitamin D.
Yeah. I think so the losartan data was coming out so afterwards. I think that there's certainly those are certainly things to consider. For something like this, I think outside of a small study, but I think that's very appealing too, because paracalcitol clinically doesn't have any really side effects. And then I can't imagine losartan, other than just watching blood pressure, should also be fairly well tolerated as well. And exploring that with some, maybe perhaps in a small study elsewhere would be, to me, appealing as well.
Yeah, it'd be interesting.
Yeah.
Perfect. Well, thank you very much.
All right, thank you.
Appreciate it. All right, we're going to move on now from trials to secondary analyses. And again, I have to really stress that this has actually been a very high, highlight of the committee's work over the last couple of years. And so we're going to get updates from our investigators who've actually done the work to actually get this done. So first, Dr. Horowitz.
All right, I should just tell you to advance or try to push the button? All right, we'll see if it works. The cursed clicker. So it's a real pleasure to be able to talk a little bit more about the secondary analysis, and I know that Sepp is going to be speaking afterwards about a secondary analysis that we performed with the GI committee looking at the SWOG 0809 trial, which evaluated adjuvant chemoradiation for patients who had resected extrahepatic cholangiocarcinoma or gallbladder carcinoma. And this was published back in 2015 in the JCO as the primary analysis. It worked. I love it. So just by way of background, the S0809 study was a phase 2 single-arm study looking at adjuvant treatment for extrahepatic cholangio or gallbladder cancer. The inclusion criteria for this were PT2 to 4, node positive, or R1 resection, and they enrolled 79 patients, the majority of whom had extrahepatic cholangio, about a third had gallbladder cancer. And these patients all received adjuvant chemotherapy with gemcitabine and capecitabine for 4 cycles, and then they received adjuvant chemoradiation. So everyone got capecitabine plus radiation to the tumor bed and regional lymph nodes. And you can see here on the slide there was sort of a range of doses that patients received. Everybody got 45 gray and 25 fractions to the regional lymph nodes, and then either a sequential or simultaneous boost with a variety of different techniques to anywhere from 52 to 59 gray. And the primary endpoint of this, they showed a 2-year overall survival of over 60% and a median survival of 35 months, which was very impressive compared to historical controls. And very notably, they had basically equivalent survival outcomes for the R0 and the R1 patients. And so that finding led to the inclusion of adjuvant chemoradiation as a recommended treatment for patients with positive surgical margins in the ASCO guidelines. And you can see that the multiplicity of radiation doses, radiation techniques that were allowed on this study really suggested that looking into how these patients did with their various techniques would be interesting. So the trial allowed for both 3D conformal and intensity modulated radiation strictly at the discretion of the investigator. It also allowed a variety of doses, again at the discretion of the investigator. And there's other data, mostly in pancreas, that shows that radiation technique such as IMRT is associated with at least as good tumor control. There are some series that show better survival and less toxicity across a variety of studies. But the effect of radiation technique and dose on tumor control and toxicity wasn't described in the primary manuscript. And so we worked with the surgery committee and Dr. Guthrie in statistics to look at disease-free survival, local regional free survival or recurrence-free survival stratified by the radiation modality, as well as acute toxicity stratified by the radiation modality. Just looking at their baseline characteristics, these patients were actually quite well matched. And I think it's worth noting that the majority of patients got intensity modulated radiation, which back in 2008, 2010, wasn't as common everywhere. Now we really think about it. And just to digress a little bit, the way that we think in radiation oncology about how to deliver these treatments, a 3D treatment, I start with the position I want my linear accelerator in, right? So I say, this is going to be my treatment field for an anterior beam. This is going to be my treatment field, and I'll draw it out for a lateral beam or a posterior beam. And then what the dose distribution within the body looks like is sort of set based off of that. Now, intensity modulated radiation, you come at it from the opposite way. I say, this is the volume I want to treat. This is the region at risk. These are the critical organs that I want to avoid. And then a computer helps determine what beam geometries and beamlets will deliver that dose distribution that I want. And so it's sort of planning it going forward or planning in reverse. And so you can really create just a much more sculpted treatment with IMRT versus 3D. But again, these patients were very well matched in terms of how they were treated, whether it was 3D or IMRT. And interestingly, disease-free survival was really equivalent between these two arms. It was about 59 and 52% for 3D versus IMRT. That was not statistically significant. And local recurrence was seen in 7 and less than 11%. Again, was not statistically significant between these two arms. And that's, again, consistent with something we've seen for most pancreas papers. There's data that suggests that for other disease sites that treatment breaks can negatively influence outcomes, and we wanted to see whether patients had more treatment breaks when they were getting treatment of larger volumes with 3D radiation versus IMRT. And we did not see really significant differences in the treatment breaks, and patients who had treatment break didn't have differences in overall disease-free survival, local recurrence, or distant metastatic disease status. This is a busy table looking at toxicity, acute toxicity from the radiation phase of their treatment. And while overall there was not a statistical difference, I think it is worth noting that grade 4 and grade 5 toxicity was only seen in the IMRT arm, which is not what we were expecting. And so, in terms of our discussion, we didn't see significant differences in disease-free survival or local recurrence looking at the different radiation modalities. Treatment break didn't seem to have a significant difference. And again, while there were not statistically significant differences in the overall rates of toxicity, high-grade toxicity was only seen in patients treated with IMRT. And when you have such exquisite sculpting of radiation doses, particularly in the postoperative setting where you have bowel that can be adherent to the volumes that you're trying to give high doses to, I think that it really highlights the importance of radiation plan quality and highlights the need for prospective review of radiation plans on these studies. And that's something Dr. Kacznick really has driven home with other studies looking at anal cancer, but it's essential, especially for a relatively rare cancer where we don't treat these all the time. And the other discussion that's important is that the optimal target volumes for irradiation in these settings are not well defined. On the study, you're treating tumor bed, you're treating portal vein, celiac, and retropancreaticoduodenal nodes. There is no U.S. consensus for what volumes to contour, what volumes to treat for extrahepatic cholangiocarcinoma or gallbladder cancer. There is an Italian consensus that lists what a group of expert radiation oncologists in Italy think should be treated, and they're very, very different than what was used on this study, treating much more extensive nodal regions, including left gastric and periaortic nodes. And so I think it's also worth noting heterogeneity in volumes that need to be treated just depending on your disease site and the type of surgery that these patients have had. Resection for gallbladder cancer is not the same as resection for extrahepatic cholangio, as you know better than anybody. And so I think that honestly, if there's a takeaway from this, I think that there's need to better define these treatment volumes going forward. And I think that any effort would need to be done in conjunction with surgeons as radiation oncologists try to define this. So with that, I'd like to open up for questions or comments.
Great. Thank you, Dr. Hortz. That was great. Yeah, I think that more and more we're finding that our lives and our patients are intertwined. So I think this is great to have this collaborative effort. Questions from the floor or the virtual attendees? Yeah, I mean, this is one for me that, this comes up over and over again, that we always think of when we design trials, radiation, and it's like saying radiation is all one encompassing thing. So I think this kind of work is actually really important. I'd love to see this, in other areas as well, particularly in trials that we've already, have data on. I mean, it's like a gold mine to tap. So
Absolutely.
and you find these kind of small differences, as you saw in the grade 5 toxicity that was not necessarily expected based on the modality. So it was great. All right. Any questions? If not, we'll keep the theme the same study, and we'll have Dr. Golami talk about her secondary analysis and just give us the status.
Great. I can't share, it says here. Somebody give me some power.
Did you click on your
It
Zoom?
says, well, let me try one more time. Is that good?
Yep, there you go.
My entire life here. Okay. All right. Well, some of the background may be repetitive, so I apologize for that. But essentially, David and I were, put two particular questions together, one of which obviously he already presented. And the second question was really, what is the role of this chemoradiation in patients with lymph node positive disease and biliary tract cancers from the same, obviously, trial that we just discussed. So as a very brief background, again, can you hear me okay?
Sep, hold on a second. We see yours on the virtual screen, but not on the main screen here.
Oh, I see. Okay. That I don't know.
Yep, we're working on that. Yeah.
I'll wait.
So, yeah, our IMS crew is going to take over the presentation. Do you want her to unshare? Is that? Oh, okay.
We'll wrap it back together.
Okay.
We both see.
But I would say just for this group, and for those listening at home, please do go out to the SWOG, website, see what the completed list of trials, if there's something of interest, if there's a question you have. This is a very, as you can see, a lot of this data is really just readily available. So for the right question, we can get your help through stats and Dr. Kacznick and Dr. Ahmad. All right, I think we're good. Go ahead, Sep.
Okay, do I have control over it?
Those, he should reclaim it.
You need to reclaim it.
Reclaim it, okay.
Yeah.
Okay, I think I have control. All right, sounds great. Basically, just to give you a little background is that, when we look back, then there's been meta-analyses that show that patients with resectable biliary tract tumors, which include extrahepatic as well as gallbladder cancers, had an increased risk of death if they're node-positive disease. And we also know that those with high-risk patients have benefited from adjuvant therapy. But again, the effects of adjuvant chemotherapy, which adjuvant chemoradiation, which essentially I will refer to, but it really means adjuvant chemo plus chemoradiation here in this setting, of node positive disease has never been determined in a clinical trial. As David just discussed, the S0809 was really the only clinical trial that really looked at the effect of this combined adjuvant therapy in a clinical trial. And then so we therefore wanted to look at that particular question of what is the role of this treatment in patients with node positive disease. So just as a quick reminder, 79 patients with extrahepatic cholangiocarcinoma, as well as gallbladder cancer were included. The therapies were adjuvant chemo for 4 cycles, followed by adjuvant chemoradiation with capecitabine. And then, as he mentioned already, the survival curves were shown in the survival, which made this a positive trial with a 2-year estimated survival of 65%, which is significantly longer than the historical control. Now, when you look at the patients and the methods that we had, we looked at all patients who received their complete adjuvant plus the chemoradiation. So from the 79 original patients, 10 patients did not complete their radiation. So those were excluded from the analysis, which then puts about 24 in the node negative disease and 45 patients in the node positive disease. The characteristics were fairly balanced, well balanced, except for patients with male patients had a higher degree of like N1 disease versus females. And then if you look at specifically lower here with between the disease sites, patients with extrahepatic cholangiocarcinoma had a higher rate of N1 disease compared to gallbladder cancers. Otherwise, resection margins were all similar, and David already discussed the radiation modality changes. Looking to the right, the overall survival was, there was a trend towards higher overall survival as well as PFS in those with N1 disease. However, these graphs did not show any statistical significance, which is not what we were looking to prove anyways. What we really wanted to focus on was like the local and metastatic disease, and in terms of the N1 stratified by N1 versus N0, and specifically seeing whether there was a difference. If you look at to the left, the local recurrence for the N1 versus the N0 disease was very similar, with 8 and 11%, but then the distant metastatic disease was significantly higher for the N1 versus N0 disease. So this made us think that, perhaps this adjuvant therapy is helping with the local control rate of these tumors compared to the metastatic disease as expected. Now then finally, our true hypothesis was based on, the comparison to historical control. So what we did is I went back to all the literature and really tried to find a good comparison control for patients with either extrahepatic cholangiocarcinoma as well and gallbladder cancers with resection alone, which was actually really difficult and quite of a task to find out. But basically, after screening a bunch of papers and coming up with sort of the best quality papers, we found out that the historical DFS as a median for the N1 group was about 13.7 months versus the 39 months for the N0 group. Furthermore, we then, with the help of our statisticians, helped to convert that into a 2-year DFS, which then for the N1 group equaled to, almost 30%. And then looking at the SWOG 0809 2-year DFS for the N1 group, that was 49%. So clearly a very statistical difference, which made this a positive study endpoint for us. So we therefore, can really claim that the patients with N1 positive tumors had significantly longer 2-year DFS compared to the historical control, which was our original hypothesis. So I think in conclusion, we can say that this adjuvant treatment following curative resection for extrahepatic cholangiocarcinoma as well as gallbladder cancer provides a favorable outcome, really regardless of the nodal status. The data suggests that the adjuvant chemoradiation may positively impact local control rates in node-positive patients. And furthermore, it really helps to be set as a benchmark for future adjuvant clinical trials, including molecular targeted agents that are currently undergoing. And lastly, I just wanted to share that, I don't know what this is doing now, that we did, we have it all uploaded for submission for Annals of Oncology. And I really want to thank really Flavio, Sai, and Lisa for really helping both David and I, sorry, my COVID brain, to really help with this. It was really awesome to be able to do this study. I think for those who are interested in looking at secondary analyses, I honestly didn't think it was going to this straightforward. The process was pretty straightforward. We wrote a very short, quick proposal, laid out the statistical design and, had a lot of help from the statisticians, and they did really all the groundwork. So I think, again, thank you for the opportunity for both David and I.
Well, kudos for getting the project through the finish line. So I think in the interest of time, since it's already submitted for a paper, we'll just move on to the last presentation, which is Samir Patel talking to us about dose density for pancreatic cancer.
Thank you, Flavio. I appreciate the opportunity to present our data. And so, can everyone see the slides?
Yep.
So I think this group doesn't need to know, everybody already knows that for pancreatic cancer, multimodal therapy in particular, systemic therapy plays a very important role. And with that, if we look at the best available data with Prognostic 24, we can see that our 5-year overall survival, not just for resectable, but just kind of overall is kind of just surpassed kind of the 10% mark. One of the issues with systemic therapies, especially for resectable patients, we really don't know how much is really sufficient. Most of the studies really talk about 6 months duration. The problem with duration is it doesn't really take into account the number of cycles patients miss. If you look at the cycles, unfortunately, it doesn't really consider missed or reduced doses. And if you look at doses, it doesn't really consider the optimal time period in which these patients should receive it. So the way in which to try to quantify the total duration or amount of systemic therapy patients receive is dose density. And this is really looking at the total amount of chemotherapy patients receive divided by the total amount of chemotherapy that was actually planned. So if we look at some of the prior studies, whether in the adjuvant setting in large part, for instance, SPAC3, they start to touch on that a little bit, where they do note that patients in this study that received either adjuvant, GEM, or 5FU, those patients that were able to complete all 6 cycles of adjuvant therapy were found to have an improved overall survival compared to those patients that weren't. And if we look at the remaining kind of big players as far as the adjuvant trials from CONCO1, SPAC4, JASPAC, and Prognostic 24, they do mention median dose densities that patients receive, but never really assess the prognostic value of it. Even Prognostic 24 noted that the GEM arm was able to achieve a dose density more than 70%, which historically has been considered the gold standard. 90% of patients that received GEM, but it was only less than 50% of patients that received the FOLFIRINOX arm. And so we looked at our institution to try to determine if there's prognostic value of examining dose density. And so in our limited cohort of patients where we actually had complete chemotherapy data, we examined dose density for the neoadjuvant as well as the adjuvant group. And we found that a cutoff of about 80% was where these patients stratified as actually having prognostic value. And in the multivariate analysis, we actually found it was the strongest predictor of overall survival for this patient cohort. The problem with our study was that it was a single institution and there was a very heterogeneous cohort in that not all patients received the same duration or regimen in the neoadjuvant or even in the adjuvant setting. There were variations in planned cycles as well as not really taking into account complete dose reductions. So in order to try to better address this and examine this, we found that 1505 is really more of a homogeneous and pure cohort to study sense. So this was a more recent study by Devendra Sohal that looked at 102 patients with resectable pancreatic carcinoma that were randomized to one of two perioperative regimens, either modified FOLFIRINOX with a 2-week on, 2-week off cycle, so 3 months before surgery, 3 months after surgery, versus Gem/Abraxane with a 3-week on, 1 week off. Again, 3 months before surgery, 3 months after surgery. And so the goal of the study was to validate if chemotherapy dose density with Gem/Abraxane and FOLFIRINOX was prognostic of overall survival. And we examined this by trying to look at dose density, which we again defined as total amount of chemotherapy received divided by the amount of chemotherapy planned. And so the way we did this with the help of Catherine as well as Sarah was use a landmark analysis. The intent of this was really to examine and try to evaluate the association between dose density in this situation and survival. And it also helped kind of provide a more realistic analysis by limiting the immortal time bias that we oftentimes see in many of the studies and associations. One of the challenges with this, however, is that we can choose a landmark time period that may not be accurate and can lead to misclassification errors. And so in order to address this, we really chose two separate landmark time periods. The first was right after surgery. So this took into account the 73 patients that received the first 3 cycles of chemotherapy and then waited to surgery. The second one, we looked at about a 40-week time period. And this took into account patients that received essentially all 6 cycles of systemic therapy. So basically the 3 months before surgery, the 3 months after surgery, and then the 16 weeks that were around the time of surgery as patients were leading up to and then recovering from the operation. And so what we found was when we looked at the first landmark, so again, looking at patients from cycles 1 to 3, we found that in the 73 patients, a dose density of 85 was actually prognostic of significant overall survival. With a group that were able to receive more than 85% dose density had a median survival of almost 40 months, so 38 months, compared to 17 months in the patients that didn't receive the 85%. When we looked at the actual percentage that were able to receive this higher dose density, we found that more than half of these patients were, so 56%, which is more than what was seen in the Proteus 24 adjuvant study. We then looked at our clinical pathologic data to see if there were differences in the underlying variables between these two groups, so greater than 85%, less than 85%. We found there were no differences in the patient's performance status, BMI, type of operation, or the complexity of the operation. However, not surprisingly, we did find that the group that were able to receive less chemotherapy actually had a higher rate of grade 3 adverse events related to chemotherapy. Next, when we look at the second landmark with cycles 1 through 6, we found that there was a lower dose density stratification of about 70%. So this is going to be a prognostic of changes in overall survival with the group able to receive more than 70%, median survival of 32 months compared to 14 months in the group that were able to receive less. And in this group, we did take into account patients that not only received cycles 1 through 6, but then also underwent surgery. And so we also had some additional secondary analyses, but we found that dose density was not associated with rate of marginal positivity, major pathologic response. And although we wanted to look at CA19-9, those data weren't captured in the SWOG 1505 study. Interestingly, and although they're limited in sample, we did look to see if we found patients that were able to receive higher dose densities for cycles 1 through 3, as well as through cycles 4 through 6. How did those patients do? In group 1, where patients were able to receive high doses of everything, overall survival was about 40 months. In group 2, where patients were able to receive higher doses in cycles 1 through 3, maybe not as much for cycles 4 through 6, their median survival really wasn't that much different. For group 3, where they weren't able to receive high doses for the first 3 cycles, but were able to receive more in the adjuvant setting, their median survival was still better, but it dropped by about 10 months. And finally, in group 4, the group that patients that didn't receive very high in the neoadjuvant or an adjuvant setting, median survival was 18 months. These data need to really be taken with a grain of salt just because the sample size are so limited, but it is a little bit provocative in thinking that most of the benefit of neoadjuvant or systemic therapy really derived within the neoadjuvant period. And so really summarized and found that dose density truly does carry prognostic value in these patient populations. That in the preoperative setting, a stratification by 85% seems to be where this lies. And then if you take into account all cycles, it's about 70%, largely from the adjuvant group. Not only that, but patients, not surprisingly, are able to tolerate much higher doses of dose density in the neoadjuvant setting. And the may reflect that the survival benefit of chemotherapy may be more pronounced in the neoadjuvant compared to the adjuvant setting. There's still several more analyses that we need to do before kind of finishing up the abstract, as well as kind of going to the next steps. So, initial data analysis that we can share.
Great. Well, thanks, Amir. I think it's kind of an interesting way to look at things, and again, also applicable to other disease sites. I know we're running a little bit over, but if there's any questions from presenters or the floor. I do think your last statement was quite bold, and as you know, there's a trial on the Alliance trying to answer that question with FOLFIRINOX, obviously not with Gemabraxane, but that is one of our biases.
As a reason, it's on the slide, but not yet in written format.
Got it. All right. Well, I think we're 5 minutes over, so I want to thank everybody again, the presenters, both here live in Seattle and at home for listening in, and hopefully everybody has safe travels home, and we'll see you at the next Zoom call. Thanks.
Get better, everybody.
Get better, yes. Bye.
That's amazing. So what meeting was that? It was our RHPDA. Oh, hey, Cameron, I thought I saw you in the audience. Working away. Yeah, exactly.